These are my financial disclosure. So I start off with a clinical case. This is a 5-year-old Chinese boy. Parents have high myopia and not wearing glasses yet. Now parents are keen to delay the onset of myopia. So on examination-wise, particularly cycloplegic refraction, patient is a low hyperope, plus 0.25 in the right eye and plus 0.50 in the left eye. Otherwise, the rest of the ocular examination were unremarkable. So here comes the million-dollar question. How would you manage the child at this point in time? Low hyperope, also pre-myope. Would you A, monitor the child? B, advise for more outdoors time? C, prescribe single vision glasses at this point in time? Or D, start atropine eye drops? So for those who have chosen B, that's what I would do as well. So I would advise the child to spend more time outdoors and at the same time cut down near work. This is so because of the IMI paper. It's shown that 2 hours per day of outdoor reduce the odds, which is the onset of myopia, and as well as the odds of reduction of additional hour per week is 2%. And outdoor time also does slows down the rate of X-linked progression. So we follow up with this child again. Now 2 years later, this child is 7 years old. He has developed myopia since 2 years later from pre-myope. And parents are working adults. They are busy working and unable to fulfill the outdoor requirements. It's impossible to bring the child outdoors 2 hours a day. So patient is now based on cycloplegic refraction again, a low myope, minus 0.50 in the right eye and minus 0.75 in the left eye. There's some X-linked progression as well. So when we do the cycloplegic refraction for him as a 7 years old, we notice that he does have anxiety towards installation of eye drops. So struggle with cycloplegic refraction. And parents have also learned about some specific myopia control glasses. So what would you do at this point in time? How would you manage the child? A, prescribe single vision glasses. B, bifocal glasses. C, progressive lenses. Or D, none of the above. So I hope the audience have chosen D, none of the above. And why so? This is because currently we have evidence-based myopia control spectacle lenses. The first in the market was the defocus incorporated multiple segments by Hoya, known as the DIMS. And this is the DIMS technology, which is a honeycomb technology with a central clear vision zone. So the logic of these lenses is that it induces peripheral defocus, allowing light rays to land in front of the retina instead of behind the retina. Next, we have the highly aspheric lenslet technology, also known as the HOT technology, which is by Essilor. Similarly, this does have a clear central vision zone. Design is slightly different, but also based on peripheral defocus design. After which, recently we have also the CARE lens, which is the cylindrical annular refractive element, most newest in the market, which is by Zeiss. Design is also the same, very similar, which is a peripheral defocus. This is with a micro cylindrical array and clear central vision zone. And there's currently also in the literature there is different mechanism, which is the diffuse optics technology, which works by decrease in contrast sensitivity of the retina instead of the usual peripheral defocus mechanism. So as you can see, once the glasses is in, the contrast sensitivity reduces. So how about 2 years later? This child is now currently 9 years old, school basketball team captain, and would like to consider contact lenses because glasses pose a significant inconvenience to the child. So he is now minus 1 diopter on the right and minus 1.5 diopter in the left eye. So at this point in time, child wants to play sports, previously was on myopia control glasses. How will you manage the child? A. By single vision soft contact lenses, B. Rigid gas permeable RGP lenses, C. Auto-K lenses, or D. Dual focus contact lens. So these Auto-K as well as dual focus are evidence-based that is currently in the market. So peripheral defocus soft contact lens and my side is by dual focus lens design as well as Ability One Day by Johnson & Johnson. These are daily disposable soft contact lenses that comes with myopia control function on top of refractive correction. They are currently non-toric in nature but can correct sale of up to -1 diopter through spherical equivalent correction. And also the more well-known Auto-K hard lens that we wear overnight. So 2 years later, now the child is 11 years old, taking major exams for primary school and would like to counter the excessive near work because they tend to read a lot during exam periods, leading to myopia progression. He is now -2 diopter in the right eye, -2.5 diopter in the left eye. He's still a low myope, but there is some progression due to excessive near work. So how will you manage this child at this point in time? He's on contact lenses because he's a school captain. So will you add low dose atropine eye drops, moderate dose, high dose, or add blue light therapy? So in this case, I will add on low dose atropine on top of contact lenses. So low dose atropine, as we know, ATOM study, ATOM 1 and 2, as well as the LAMP study, has proven its efficacy in terms of slowing down the rate of myopia progression. How about combination therapy, you may ask? Has it been proven to be evidence-based? So we have a few studies here since 2019. So Chen study, which is Auto-K with low dose atropine, shows that yes, on the left-hand side you can see a tick that is efficacious in combining treatment. 2020, also Auto-K with 0.01% atropine. It does shows that it is efficacious to combine low-dose atropine with Auto-K. How about 2022? Adenos study, 0.01% with peripheral defocus soft contact lens, defocus contact lens, as well as progressive lenses. Adenos, however, disproved that adding atropine has any additional benefit, so it's a cross over there. So how about another study in 2022? It is for poor Auto-K responder when we add low-dose atropine. Does it matter? So it's no, because they are poor responder. 2022, another study by Shi, 0.01 with Auto-K. Yes, it does shows that it does help. And another study in 2022, defocus soft contact lens with 0.01% by Adenos. So this study again doesn't show any benefit in combination treatment. And 2023, DIMS, which is the Hoya Myosmart with 0.01, it does shows benefit. And finally, 2024, Adenos did another study with 0.05% atropine this time round. Combination therapy, yes, it does shows benefit. As we can see, it is a mixed response, but recent study does have evidence to show that combination treatment does work. So 2 years later, the child has stable myopia, minimal progression, on low-dose atropine as well as soft contact lens. How would you manage this child? Will you continue treatment after 2 years? Extend the follow-up duration from 6 months to 1 year? Taper off atropine eye drops? Or discharge the patient? You don't have to come back and see us anymore. So I will taper off the atropine eye drops, and the reason being the risk of rebound. So if we stop atropine eye drop abruptly, as you can see, there is significant risk of rebound in spherical equivalent as well as axial length rebound. As you can see, is significant. So even ATOM 2 study shows that there's 24% of rebound of more than 0.5 diopters if we just treat for 2 years and stop for the whole entire 1 year. So what do we recommend? Taper atropine eye drops. Every 3 monthly, cut down the frequency. Instead of every night, do 6 nights, 5 nights, 4 nights, and so forth. So myopia is evolving clinical management. I just like to end off that. We started off from atropine to auto-K, followed by myopia control glasses, myopia control soft contact lens. Recently, there's also red light therapy in slowing down the rate of myopia progression. In future, there might be AR as well as VR technology. So the gold standard of myopia management should be, first, early intervention. Second, evidence-based. We should embrace all evidence-based technology in slowing down the rate of myopia progression in these children in childhood. Third, strategize. And finally, embrace innovations through research as well as aiming for commercial viability. Thank you.
Okay, thanks Lillian. We'll take questions at the end of all the speakers in order to manage time. So next I invite Dr. Jorge Ruz Medrano to tell us about the myopic differences that